morning, all. My name is Dr. AKUDO KANU, and I'll be taking us through stabilization, referral, and transport of the sick newborn. So, here my outline. Okay, here we are going to take the case scenarios and, I dive into the presentation. So, a baby boy was born at the primary healthcare center at 32 weeks gestation with the following weight, and he's having difficulty breathing with grunting and increased work of breathing. The local team has provided initial stabilization, including oxygen via nasal cannula, but his respiratory status is still not improving. So it happens that the nearest neonatal intensive care unit is like 150 kilometers away. So here is the quiz. What is the most appropriate next step in the management of this newborn? And which of the following is not a goal of pre-transport stabilization? So, I don't know, can anyone attempt the number one question? Anyone? Any attempt? Okay, maybe we should leave it when we get to the end of the discussion. I'm hearing stress. Okay, go ahead, thank you.
Is C.
What is C?
For the first question.
Okay. Escalating and commencing CPAP instead of using intranasal oxygen, right? So, which of the following is not a goal of pre-transport stabilization? Who wants to attempt? Okay. D, administration of blood transfusion. I think it's so simple. Maybe I should use another means. Okay. During transport, what is the preferred method of monitoring the baby's oxygenation? Is it by observing the cyanosis, using pulse oximetry, or blood gas analysis, monitoring respiratory rate? Okay. So what is the recommended mode of transport for a critically ill newborn requiring intervention? Beautiful. Okay, can we clap for ourselves? I think we are all good students. Okay, by way of introduction, transporting sick and, critically preterm babies to centers of specialized expertise or facility actually improves outcome. But it's good to know that, the other presenter, Dr. Love, my friend, will say that the uterus or the womb is the best incubator and the safest place the baby should be, to acquire all the baby needs. In transporting a baby, it is also safer to transport the baby in utero when you see or find out that the mother is a high-risk mom. So better the mother goes to a tertiary institution where care will be given and have the baby safely delivered, and then the pediatricians will take over. But where that is not, possible, a standardized national transport protocol across all healthcare level has been available, and this is crucial for neonatal outcome. Effective communication and emergency transport facilities are really, really essential for good outcome. So we are going to talk about the types of neonatal transfer. We have the inter-facility transfer and the intra-facility transfer. So the inter-facility transfer is like this quiz that we just had. Primary health care center to a tertiary center, or to Limi, or to University of Abuja Teaching Hospital, or National Hospital, or FMC Jabi. So those are the tertiary facilities where extensive and multidisciplinary care is given to the babies. But the intra-facility transfer is moving a baby within the same health facility. Maybe from the NICU to the radiology department for echocardiography, ECGs, or, surgeries for those that require surgery. But it is also safer for, facilities that have those, maybe echo machine, ECG machine, mobile X-ray, to come to where the baby is to have those investigations done, aside surgery though. So we are going to talk about the steps. There is a step-by-step, transfer process. First of all, decision must be taken in a child that is ill and needs or requires special care. And this decision should be taken by the most senior doctor, maybe the pediatrician, the consultant, and when the consultant is not available, the senior registrar or the chief medical officer takes that decision. And the next step is communication. First of all, you inform the parent what the baby status is, what the child has, the indication for referral or transfer, and give them a breakdown, detailed breakdown and reason. Then you will bring to the table the referral hospital where you're going to take the baby to. And we have this place, we have this facility. Where do you prefer? Where would you think is convenient for you to go to? And allow them take the decision. But you will also bring your own, expertise. I think it will be preferable here. I think it will be preferable there. Discuss the benefits and risk of transfer. Benefits, the child will do better, there will be good outcome. And as you're talking about that, you will talk about the risk, things that could happen on the way, things that could happen on arrival at where you have referred the baby to. One key thing, ensure you obtain informed consent before proceeding. Some of them will now say, no, we love it here, we don't want to go. But if that child really needs that care, and it's not obtainable where you are at, serial counseling, keep talking to them. Time is of the essence, keep talking to them until they give their consent. Then you provide a formal written referral letter. So we will talk about this later in documentation, but this is a sample of a two-way referral form where the newborn details, address, parent's address, the referring hospital, and the name of the care provider is documented. Then when you get to where you have referred the baby to, they will also fill this form. It's kind of a checklist that helps you or guides you on what to do, what you have done, and where we are. And this is very vital. Litigations everywhere. Documentation is very key. And also, aside that, this will help the hospital you have referred to know the things you have done, how far you have gone with treatment, and to also know where to start from. So, still talking about communication, actually, the referring hospital is supposed to communicate to the hospital they are taking the baby to by a phone call, not WhatsApp chat message or SMS, and tell them, I'm bringing a 32-weeker baby to you. Do you have space? Time is of the essence. You call them, ensure they have a space to receive the baby, and they will start preparing, getting ready, warming up incubators, putting things in place to receive that baby. And communication should be a continuous thing. As you're leaving or you're preparing to refer the baby, you're communicating with them, this is where we are, and all that. Outside that, we will talk about the pre-transport stabilization. I remember when I started my residency newly, but this one, the example I'm going to give is like an intra-facility transfer. Then, but I don't think it happens now. Maybe a woman delivers a baby at the staircase, maybe, unbooked mother. You will now see people or nurses carry the baby and be racing to the NICU. Doctor, 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 doctor. And this is a tiny little baby that could, rupture the vessels, have intracranial hemorrhage because of this rigorous, agitation and race. Sometimes even from the labor ward, you will just see people running. I was like, what is happening? What is happening? They are carrying the baby and they are, they just running up to you instead of, trying to stabilize first. That is why we are all here, to learn how to stabilize these babies and gently, move them. And when you get to where you're taking them to, you do a proper handover. So transfer should only occur after the baby is resuscitated and stabilized by the referring hospital staff. And the goals of stabilization is temperature stability, respiratory, cardiovascular, metabolic, and antibiotic administration if need be. So temperature, what is the normal temperature? We have the auxiliary of 36.7 to 37.5. So, the newborn, they don't have the brown fat and all to kind of contain or retain temperature. So it's light, tiny skin, subcutaneous tissue, they are all just, preterm and all. So evaporation of fluid and, stuff. So they are not able to contain or maintain adequate or maintain their temperature. So what do? We held them. So maybe later we'll talk about, because here that's where, thermal stability comes in, incubator care, radiant thermal use, and, wrapping them up with clothing and all to keep them warm so that they will feel like they are still in the womb. Then respiratory stability, we will not overemphasize that. Dr. Peter had already talked about, all the ABCs, positioning, clearing the airway, and all that. Breathing, ensure that the child is breathing normally. In the newborn, what is the respiratory rate? Who knows? Of a newborn baby or preterm babies. You can just echo it the way we did earlier. Okay, so you just ensure there is normal pattern, respiratory rate is within 40 to 60 beats per minute, and there is no, chest indrawing or increased work of breathing. But if you notice that, administer oxygen. But in the preterm babies that that they are at risk of having respiratory distress syndrome, which Dr. Taiwo talked about, its prevention, you commence the CPAP. Then when the child you've done your resuscitation and is not stable enough, you can do the bag and mask for irregular breathing. Dr. Bita talks about that. Intubation when there is prolonged ventilation, and consider administration of surfactant. So this intubation and all, and the using ventilators and CPAP is going to come up later. So just get your seatbelt fastened. So cardiovascular, we ensure you have IV access and ensure that their babies have a warm, extremities, capillary refills are good, activities are very good, blood pressure, if you have appropriate cough, it's also good. Then oxygen saturation, remember I said it should be greater than 90%. Ensure that the child is not hypoglycemic. Also, in centers that could have electrolytes, urea, creatinine done, we could, find out if the child has metabolic acidosis and correct appropriately. Antibiotics if need be. So these are the things we do before we transfer. But there are special cases, especially those babies with, some form of malformations. It could be the neural tube defect, or abdominal wall defect, or GI defect and all that. So this is how we stabilize them, because we don't want those, organs that are protruding to get contaminated, get, traumatized, or, get injured at all. So for omphalocele or gastroschisis, just pass NG tube, decompress the abdomen, cover the intestine or whatever the abdominal content with a warm saline gauze to prevent trauma, infections, and all. Same with neural tube defect, diaphragmatic hernia, intubate also and decompress the abdomen so that we don't have, respiratory issues. So the next step is transporting the mode and accompaniment. There's another experience I had when I started my residency newly. My first call in NICU, I had a baby that came in, a 1 kg baby that came in from another town. I actually did that in Gwagwala, that brought from another axis. They came with this tiny little baby wrapped in the mother's wrapper on a bike. Now. So it's just, unfortunate, but the good news is that the baby made it and went home. So mode of transportation depends on availability, urgency, and the terrain where the facility is, the hospital is. KMC position is the best clinical permissible way to, in case there's nothing one could do. That's mother-child contact, wrapping the baby. We are going to also talk about that later. It's even safer and, gives the baby and the mom opportunity to bond and to maintain temperature. So ambulance is actually the preferred mode, but where it's unavailable, like in primary health centers or maybe all these hospitals here and there, they could use car, boats in people that live in riverine area, because this baby actually needs, maybe surgical intervention or expert care. Air ambulance are options too. So the accompaniment should be with the mother, a nurse, and a doctor. And it should be in an ambulance. And the medical personnel, they are supposed to be sure they are, keeping an eye on the baby, ensure that nothing goes wrong under their watch. So babies at risk requiring intervention like post-op care or any multi-organ support should have medical personnel with them, but routine care babies may really not need medical personnel escort. So, okay, care during transport. I think I've talked about some of these things. Ensure resuscitation equipment, drugs, fluid, consumables are in the ambulance. Suction, maybe the bulb syringe or anyone. Sufficient oxygen are available in the ambulance. Okay? And in other, like we have our mobile incubator, in the ambulance, you could also have like CPAP. There's a mobile CPAP machine, which is like rechargeable that, one could use and travel. So also ensure that the airway maintain neutral position, intubate if there is need, but you would do the intubation at the hospital, referring hospital before, taking the baby off to where he will need expert care. Ensure that circulation is at par. Monitor perfusion. Ensure IV fluid are running at prescribed rate. Oxygen is being monitored. That's where our answer came from. Continuous pulse oximetry. And ensure that the SpO2 is greater than 90%. Then observe for other telltale signs that could show you some form of deterioration as you're moving. Babies on IV fluids, watch out for altered sensorium or respiratory distress in case the fluid ran faster or quickly. But our eyes should be on the goal and on the baby we are transporting out of our facility. Sorry. Thank you. So, handling an arrival. How to handle deterioration. It's good to know that at the time of transport and the baby deteriorates, please tell the driver to park in a safe place where resuscitation should be given to the baby, not on a moving vehicle. And you can actually stop in a nearby facility or any hospital nearby to resuscitate this baby. And as you're doing that, remember I said continuous communication from your hospital to when you took off and on transit till when you get to the referred hospital. So arrival and handover. There is a paper that was uploaded, a two-way referral form. You must have filled your own part, and then you hand it over to the receiving medical personnel there, and they will also document with your name, date, and time, and ensure that it is signed. Basically going to run the test or run the investigation to inform the person, because there are some facilities where you just carry the baby for x-ray, there is no mobile x-ray. As you're going to the radiology lab department, you just hear, what's happening? They are rushing back that the baby turned blue or baby stopped breathing, and they didn't go out with anything, no ambu bag, nothing. That is too risky. Our aim is to, ensure that these babies are, handled with care, caution, to wherever they are going to without any bad outcome. So in conclusion, safe and effective neonatal transport is critical for improving outcome of sick babies. And there should be a standardized protocol involving 1, clear communication, 2, thorough pre-transportation stabilization, 3, appropriate documentation, careful monitoring during transition of the baby from one place to the other. Both inter-facility and intra-facility transfer require careful planning and execution to minimize risk. Thank you so much for giving me your ears.